Hello and welcome to the World Extreme Medicine Podcast. I'm your host, Stephen P. Wood. I'm an EM and critical care nurse practitioner, medic, podcast host, and Wilderness Extreme Medicine fellow. And it's great to have you joining us today. We know that there are a lot of podcasts out there and a lot that you could be doing with your time. We're thrilled that you're spending your time with us for today's podcast. And I'm excited today to have Dr. Sanjey Gupta. He's the Chief of Emergency Medicine at Northwell Medical Center in New York. He's a wilderness enthusiast, wilderness educator, and he's going to talk today about a really important topic, bringing wilderness and extreme medicine to the virtual world. Dr. Gupta, take it away.
All right. Well, Steve, thank you again for the invitation to join your podcast. I'm always very excited to talk about wilderness medicine and education and combining the two. I think wilderness medicine education is always very unique in that it is, truly a simulated type education, but in an in situ type of environment. So we're best to teach about wilderness, fracture kind of splinting than in the wilderness. We go out, we mimic a scenario out in the field, but we actually get people to take branches of wood and split folks. So wilderness medicine education is greatly suited to combine those elements of outdoors, in situ simulations, which usually keeps learners really engaged from so many things. But just like the pandemic has challenged us in so many different ways, education has been a part of that. So notwithstanding, I'm an emergency physician, so we had the challenge of continuing emergency medicine education in environments where we had to be socially distanced and utilize proper sanitation techniques like masks and limited exposure times. So that affected and forced us to alter the way that we provide education for physicians in that environment. But what do we do with our wilderness students? So as much as we wanted to still provide this education, it sometimes seemed a little insurmountable of how do we provide this education for treatment in remote environments when we can't really be in those remote environments together, or we can't even get out to those remote environments. So, in kind of thinking about this and brainstorming with many of my fellow educators on the topic, we had some good ideas that came out, and there's some collaborators that I've worked with over the years where we've always done a really kind of innovative and kind of leading edge job in trying to think about different educational techniques. Some of these folks are Henderson McGinnis at Wake Forest and Stuart Harris up at Mass General. And one of the areas where we had an opportunity to try to employ one of our new ideas, one of the places was actually the Southeast Wilderness Medicine Conference earlier this year, which was entirely virtual. And we were charged with doing an improvisation session. So, our usual format with this would be, let's bring a bag of stuff. And the stuff can be, random things you might have, bike inner tubes, a license plate, some rafting straps, things that you might have on hand, a bike pump, and, talk about scenarios, but actually have students in real time think about the provision of care of people without having our traditional, x-rays and plaster or fiberglass to help take care of different clinical situations. So, the idea came about of, why don't we kind of flip this around? Why don't we provide a scenario where our learners, wherever they are, most of them were home, could actually run an improvisation session based on a real world scenario, much as we do when we're together. So we really here on the East Coast and any other part of the country, we're really looking at Texas this past winter and the tough time they had with the extreme cold. We're not really prepared for that sort of thing. So we know there was a lack of potable water in places, electricity, heat, and tough to manage conditions. So we thought about that and thought about how we could use that experience of the folks who kind of had to unfortunately suffer through that, but how can we use that as an educational module? So we turned our improvisation session into a somewhat of a survival session, some of these, self-care techniques that we all have to have as wilderness educators out in the field, or providers out in the field. So we actually built scenarios. We had participants, and this was all on Zoom, join us, and we provided them these scenarios. It started with, this is your scenario. You are in an environment where it's 20 degrees, you have no potable water, you have no heat, you have no electricity, and you have to actually provide yourself potable water. So how are you going to do this in your home environment? And, with also the added stress of you don't have electricity, you don't have gas, so you can't boil anything. And, it really was pretty interesting how this played out. The students were kind of, at some level, not prepared for this kind of reverse improv. Like, suddenly they were the participants in a situation and they had to get themselves out. But it came up with some really kind of fun and interesting outcomes. We had some students who certainly went and thought about this, and many of them had the Poland Spring bottle, so they came up with that, going, "I'm good," which is fine. But others, and it was interesting. Some of them, with the drops of bleach, 1 or 2 drops of bleach per liter. There was some prior knowledge, but some really thought outside of the box a little bit. I mean, one example, and this was new to me, and I have to think about this. Someone brought vinegar, going, I use vinegar to wash my fruit to sterilize it. So maybe there's some proportion of this that I could use in water to make it potable. So it was just getting the creative kind of juices going, and kind of, people thinking in that kind of real world, real time, limited resource environment of how can I answer this question, much like we would have done in our kind of in-person improv sessions. And, a second scenario we brought up that day was also a light source, going, hey, listen, you're not prepared, you don't have a flashlight, you don't have a candle, your cell phone's out, so you can't use that as a flashlight. Like, how can you provide, a light source in your house? And, some of the answers were pretty interesting. Someone built a potato battery, which I thought was great. I don't, like, no joke, with a light bulb. And, another, thought this was creative and something that I never would have thought of, but, LED lights in the house. I have a 13-year-old daughter. She loves her LED lights, but actually took those LED lights, put a battery to it, and we realized, yeah, a lot of people have these LED lights around. They don't require much electricity, and you might be able to splice wires to build something in real time. So really kind of a fun, session with some learning. I think, the idea is that we were able to kind of bring about this idea, some of the concept of, survival techniques, but more the thought process of improvisation without people having to leave their house and actually using whatever items they had sitting around, which is often what we do for in-person improv sessions. I would say if I had to do it again, the thing I would do is probably prepare the students for the session without revealing what it was going to be, because you really have to be willing to be involved. It was more of laying out the scenario, sending the students out, giving them a block of time to build or get at whatever they were going to come back with, and then they were going to present their ideas, and we would give feedback in real time for kind of group learning. Some of them were not as enthusiastic about getting up and, running around their apartments or their homes to do this. So, next time I would certainly have laid out some objectives a little bit more clearly, with also the intention of this is hands-on. You have to participate to get the the most out of this. Just in some level to weed out the people who really may like more passive sort of education better. So we thought that was pretty successful.
Sanjay, no one came up with vodka or tequila as a good diluent for sterilization.
That
might have been my first thought.
Yeah, I was surprised. Maybe it was a group of teetotalers, but it was discussed. But no one pulled out their like Tito's, and a glass. So
okay, yeah, something to think about for the next session for sure.
Absolutely, and I think another big opportunity that we had was that every year at Society for Academic Emergency Medicine, we run an 8-hour wilderness medicine workshop. So it's usually about a group of 10 of us. Many of these folks are well-known leaders and educators in the field. Many of them are fellowship directors across the country. So, we spend the morning doing didactic lectures on, how to build a curriculum and how to negotiate with your professional school. It's usually medical school, about getting a program going. How do you build an elective? But we usually spend the afternoon in skills. Litter building, this improv session that I mentioned. I usually run a tabletop on poisonous plants. Very multifaceted. Even how to, build a scenario, things like this. But we were charged with cutting this down to 4 hours and doing this virtually. So how do we actually do this? And we don't want to do anything that's non-engaging. It's very easy to make a PowerPoint and do a voiceover, but I don't think that's a great way to teach nor a great way to learn. And I think Zoom gives us a interesting platform, or Teams, interesting platform where you can still be engaged, but it's virtual. So we actually built out a scenario, and it was it's supposed to be a trauma scenario out in the field, touching on some of the critical actions of, C-spine, immobilization, wound management, kind of trauma evaluation, and, other things like decision making in remote environments. But we're not remote. So what we actually built out with Henderson McGinnis in his backyard, I was in New York as a facilitator. He was in North Carolina in his backyard, and he found he had his fellow and a medical student. Medical student actually staged himself as an injured cyclist. So mountain bike, with the bike, he had a backpack. This is all they had. And so Henderson and his fellow actually set themselves up as passerbys. They were out for a day hike, so had their kind of day hike packs with them, and that's all the participants had. So it turned into an interesting scenario where we staged this completely over Zoom. So we really just took a participant with an iPhone who could record the scene. These guys split 3 earpieces so they could hear the dialogue, including the actor who was on the scene and the 2 participants out in the field. We had about anywhere from range from 4 to 10 kind of participants at a time, and I ended up facilitating to make sure that everyone had a role, but we kind of acted as a telehealth visit. So imagine being out in the field, calling a ranger station, and there's an opportunity for a televisit, which apparently is occurring on Dan Network and other things like that. So it was very interesting. So I wish I had a diagram for you, but I was facilitating, being in New York. We had participants in this conference who were all over the world, on Zoom at different levels, some faculty types, students, trainees, and we had the actual scenarios staged in a backyard in North Carolina. And so we were effectively able, and the facilitation was definitely part of it, but it was able to take the participants and have them act as medical control, and it really played out well. And the Henderson and his fellow acting like bystanders who didn't know anything. So they were the hands, the eyes, the ears of these students and physicians and residents, and they had to guide these folks, these 2, into being able to assess this injured party and provide the health care. So if you think about that, this is the utilization of technology for pretty cheap, because all you really need is a free Zoom account. You need some Wi-Fi at the site where you're staging, Wi-Fi at all the sites where people are, or cellular network, and then the ability to participate. So it actually really turned out even better than we thought, where participants were talking to the actors who were bystanders who had no medical knowledge, going, can you touch the back of the neck and feel if, and ask the patient if he has any tenderness, oh, what's tenderness? The elicitation of pain on, pressing back there. And it was like, yeah. So then actually kind of then going, okay, we got to secure this, so can you hold his neck, or so it was actually going through these steps that then have to build a C-spine immobilization, virtually, with people who are acting like they did not know how to do this. It was the same thing with wound management. There was a bleeding wound, open fracture, a couple other basically injuries staged there. So it actually really turned out pretty well. I would say that most participants were actually into this. They helped, and then it took the part of me as a facilitator to make sure that everyone had an opportunity to speak, because there's often these scenarios, one or two people who like to talk the most. And we took the opportunity at the end to build out a feedback form for the participants, because we haven't done this before, and it was largely positive. And I think the crux was that wilderness medicine education can be offered in this way, but it should not be a ongoing replacement for kind of the insight to field scenario kind of assessment work and debriefing. So we were able to try to bring that kind of scenario-based insight to learning into this virtual environment, trying to provide those elements of patient assessment, hitting the critical check marks, and then doing the debrief. So we did as best as we can in the virtual environment like that.
That's incredibly creative. I mean, that's something that I don't think I would have thought of as a means for providing this educational resource. But how better can you get than, hey, let's pack a few things that they'll have available to them. These are going to be some non-medical people calling, asking for assistance, and they can utilize what's there. Try to explain how to assess, and then try to explain how to actually manage those patients. I think that's an incredibly creative way to kind of flip the narrative, and really engage people when they're remote and aren't in that actual environment. Because I know one of the things that you do is that what I call the bag of tricks, where you dump out some things that people have to make improvisational splints with and things of that nature. This is an incredibly creative way to really still engage those providers with that kind of limitation, but in a really unique way. That must have really taken some thought. I assume you're going to take all the credit for that, as you should. But no, in all honesty, really creative. And I think the other piece of that is just that the inclusivity. So, a lot of these courses aren't accessible to people that are remote, don't have travel expenses. I think of the FDNY, MSOC conference that we both participated in. For me, I live in Boston. It's a 4-hour ride down to New York. You're already there. We do have people coming from all over the country, all over the world. But for those who it's not accessible to, what a great way to bring this kind of education and learning to a much broader audience. And it makes me think of, people, especially in developing countries, who don't have the kind of travel resources that we do. Fantastic way to really bring, world-class education to that platform. So I applaud you for that. That was incredibly creative.
Yeah, well, thank you. I think when there's obviously a need, there's a way to get a lot of people engaged to think about this. So it was, I think the most challenging aspect of it was to, we had no real way to test the platform or technology before we actually did the course. So, often we could run into challenges, and it may have been a big not, but we were able to do that. We had about an hour ahead of time to test, but if we were really having challenges, we just would not have been able to do this. So it does take a pretty stable Wi-Fi network on the end user part and on the participants part, and whoever is hosting the Zoom session. But if that's really it, I think in this day and age, everyone has kind of ramped up their Wi-Fi capabilities. So it's definitely a model that could be used. It's also a model where now you can have also faculty who might be in urban settings, just like you're in Boston, I'm in New York, but we can work together and collaborate with someone who is way across the world, just like you mentioned in education. So it kind of opens up this kind of globalization of wilderness medicine education in some respects.
No, it really does, and I think that's a big positive. I think one of the limitations to all these courses that you have an opportunity to travel to, as much as I think most of us are going to be very excited to get back and see our colleagues and meet with them, and engage in live conferences and in situ experiential learning like what you're doing. This does offer an alternative for those who can't do that, and it does offer a lot of collaboration. So it opens up that we can collaborate. Like you said, I could be here in Boston, you in New York. Someone could be in Alaska, someone could be in Iceland, and we could still collaborate on a course, which is pretty exciting stuff.
Yep, and then some of the other elements of the course. I mean, with kind of these bigger conferences where there might be some budget flexibility, we were able to send to participants who had pre-planned ahead of time, boxes of materials. So as we were talking about, even things like not making. We were able to do that in real time with the same materials and reproducible with people where we could, kind of guide and help. Obviously, we didn't have the hands there with them, but we could watch over Zoom, watch them do this with having that pre-planning. But again, so many of these conferences have different types of budgets, different types of access. But, I think it opens up a world of, inclusivity for a lot of people.
Yeah, certainly. It makes me think there's an exercise that actually I learned at the Stratus Simulation Center here in Boston, which is run through the Brigham and Women's Hospital, which is you're with a group and you're told you're stranded on a boat and you're given a list of like 20 pieces of equipment that you can take with you, and then you have to prioritize what you want to basically survive. I think this is and I use this when I'm doing some education around crew resource management or teamwork, and this would be another thing. It sounds like would be really amenable to this kind of option where you can have collaboration even if people aren't together. They're thinking through, here's what's the equipment that we're going to need, why are you going to need it, and I think you could do something very similar along those lines. To what you're talking about with what you did there, and again, it's very collaborative, but it's even these participants aren't necessarily together, but they can work together in a collaborative way. And so I think there certainly are different ways to do it, and I really like what you did there, and I think that's something that I hope our listeners who are doing something similar can borrow from and use in their teaching, because I think again it's all about collaboration. Any other ideas that you guys have come up with? I know you have some of the brightest minds when it comes to wilderness medicine education. What other kind of things did you think about, like that either worked really well or that you found, and conversely, what kind of things did you find didn't work so well in what you've been doing?
I mean, that's a great question. I think the challenge that we always have in virtual environments is keeping people, interested and engaged, and a passive type learning is already difficult enough in person, and to try to do that virtually is even worse. So, in some respects, with giving PowerPoint or a similar type lecture, even though this is live, it's kind of tough to engage people, when you try to also ask them, you always like open conversations and access, and I find that, when we teach even in that kind of traditional format at meetings, it's easy for someone to raise their hand and for us to, stop what we're doing and, allow for a conversation to start. But it's seemingly more difficult in this environment, whether people are not fully engaged because it's digital, whether they're distracted, or they're just it's easy to not listen. So I find that there's a much better opportunity to certainly use more engaging formats. So I haven't personally, but I know there have been a lot of kind of gamesmanship has worked out. So using products like Kahoot and other kind of games apps, try to keep people on their toes as they're learning knowledge. Something that we've developed at my site at Northwell South Shore that we've used actually for critical care education, but not so much for wilderness, although I do have a construct in my mind. I just never got around to implementing it, is actually using PowerPoint in some respects as the choose your own adventure. So you can find some of these templates, but we really actually had honed this down. My vice chair, his name is William Afterback, who's a former high school teacher, actually really took this as a model of learning. So he constructed through PowerPoint and almost a choose your own adventure type of format, using stereo buttons, using video clips, about someone who might have some airway compromise. But I'm like, you know what? I should do this in the same way of, I mentioned a tabletop that I run in real time with poisonous plants, and that's usually scenario based. An example might be, you are in a survival situation again, and you are at home, and your food sources are running low. So why don't you go into your backyard and find some plants that are edible? So we have things like clover in there and purslane, but at the same time I'll put in some mushrooms that are often confused with your kind of button mushrooms at the grocery store. Throw some poison ivy in there, some things like that, things that might be in there. So there was a concept of writing that scenario, allowing people going down the road of looking at pictures of things, in a lawn and picking and choosing, and obviously getting an outcome, either a great outcome or a not so great outcome after eating. So that is more of a framework that we have. We've certainly built that for critical care. But that was always a framework, and that's probably the next step of doing that for wilderness medicine. Just kind of takes a while to lay out all those decision trees in PowerPoint or in the Google equivalent to PowerPoint, but you could find some instructional manuals on this online in a very limited format. But there's certainly, I think, other opportunities with some of the products that we use on a daily basis to allow for a kind of reproducible, interactive, kind of experience where you can, where I don't have to sit there as much as flip a slide, more of that I can still provide kind of that real-time feedback and tabletop type learning, even though we're not all sitting at the same tabletop.
Yeah, that's a great idea. That's another really creative way to provide this education. I think all of us, grew up doing those choose your own adventure books, going back, and choosing different paths each time. That's a really cool method for kind of teaching, edible plants versus poisonous plants. I think you could probably do something similar even with, like snakes, for those people that are in those kind of environments. I do think that, possibilities are kind of endless. Again, real creative, real, resource-oriented ways to kind of provide this education. So again, thanks. That's a really cool idea, and I think this can get people's kind of gears churning about how you could do this with a variety of different kind of scenarios. Anything you found that just didn't work, that you maybe were excited about, implemented, and just kind of fell flat?
Yeah, I mean, those were probably the two biggest educational things. When we think about clicks, I mean, we did do, again, anything that seemed to be passive. So I keep mentioning the PowerPoint with a voiceover, and that's, I think, probably the worst format that you could go by. There's some ability to superimpose a video of yourself, like kind of talking and being animated, but, I don't feel like that even provided any extra benefit to the participants, without somebody there. And there have been a couple of other opportunities to do something like that, but then have a live session for 5 or 10 minutes afterwards to answer questions. No one seems to have any questions to ask, because there's really no one left. No one survived your 30 minutes of passive discussion, to ask those questions in the end.
Yeah. Well, Dr. Gupta, this has been really informative. This is, these are great ideas, very creative. This, I think can help people that are looking to teach austere wilderness medicine in this type of format, to help kind of, again, churn those gears and get them thinking about creative ways to provide that education in a remote setting. I want to thank you again for sharing your extensive knowledge and your experience and expertise with us today. Our hope is that we get to join you live for your really excellent course, especially your again, what I call the bag of tricks, where you kind of, when I was helping develop the wilderness course for FDNY MSOC, everyone was asking for equipment like tourniquets and splints, and you were asking me for like tire tubes and license plates, which, thankfully I live in a city where you can find those things on the street. But it was really cool and really, amazing to see, your, how you put those kind of things together. So as great as it is to think about, virtual education, I hope all of us can join you sometime live for one of your courses. You're one of the best educators in the field. And thank you, listeners, for choosing the World Extreme Medicine podcast as your source of wilderness and extreme medicine education. For more content like this, please make sure to follow us on Instagram at World Extreme Medicine, on Twitter at XPEDMed, that's EXPEDMED, and to visit our website at worldextrememedicine.com. There's tons of content, including podcasts, videos, as well as links to our live events. Last but not least, and this is apropos to our discussion today, join us for the Expedition Medicine Conference in Edinburgh, Scotland, which is taking place November 13th through the 15th. We certainly want to see you there live, but there's a virtual option there as well. And Dr. Gupta hopefully will take some of your advice and integrate some of what you taught us today for that virtual part of the conference. So thank you all. Be safe. And Dr. Gupta, thanks again for joining us.
And Steve, thanks again for having me.